This is Dr. Tina Younger, and I'm here with Dr. Lilia Parra-Roide and Crystal Garcia and Dana Bray for our Quality Improvement and Patient Safety series and focusing on event reporting. So first, we want you to know we have a Quality and Patient Safety Committee. Our mission is for promotion of knowledge, engagement, and participation in quality and patient safety initiatives for the Creighton Alliance graduate and undergraduate medical education programs. Our institutions are St. Joseph's Hospital and Medical Center and Valleywise Health. Our members are faculty, house staff, nursing, medical students, quality analysts, hospital leadership, and GME staff. The ACGME, which is the governing body for residency programs, offers the optimal learning environment and to continually provide experiences to address patient safety, especially for education on patient safety, culture of safety, reporting of adverse events, near misses, close calls, and unsafe conditions, experience in patient safety event investigations and follow-up, clinical site monitoring of resident, fellow, and faculty member engagement in patient safety, resident and fellow education and experience in disclosure of events, and resident, fellow, and faculty member engagement in care transition. Our goal is to improve event reporting to gain knowledge of the areas that need improvement. The aim for our committee is by June 2021 to increase event reporting across our institutions by 20%. And to increase engagement of learners at the local unit level. Our objectives for this session are, at the end of the session, learners will state why event reporting is essential, know how to report events, know what should be reported, incorporate event reporting into your practice, and seek opportunities to learn from these events. First, we must actually talk about the gap in our healthcare delivery system. There is a quality gap between what we know to be good care and the health care that people actually receive. The Institute of Medicine in the report To Err is Human in 1999 came up with 6 aims for improvement to address this gap. They are safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. These are guiding principles that allow healthcare systems and healthcare providers to focus on areas to help improve their systems of care. Our first step in closing the gap in quality is to report patient safety events. Why is event reporting important? It is because medical errors contribute to a significant amount of preventable deaths each year. Johns Hopkins patient safety experts have calculated that more than 250,000 deaths per year are due to medical error in the United States. Their figure, published May 13, 2016, in the British Medical Journal, surpasses the U.S. CDC and Prevention's third leading cause of death, respiratory disease, which kills close to 150,000 people per year. Cardiovascular disease, cancer, and then medical errors above respiratory disease. First, we must address our safety culture. Medical errors aren't due to inherently bad doctors, nurses, pharmacists, nursing assistants, etc. And reporting errors shouldn't be addressed by punishment or legal action. Most errors represent systemic problems including poorly coordinated care, fragmented insurance networks, the absence or underuse of safety nets, and other protocols, in addition to unwarranted variation in physician practice patterns that lack accountability. Event reporting allows the organization to look at this complex system that led to the errors so that we can prevent that error from happening the next time. So, patient safety. Patients should not be harmed by the healthcare system that is supposed to help them, but the solution does not lie in assigning blame or urging health professionals to be more careful. What it does mean is that we need to have a commitment to zero harm. That means 0 complication for patients, 0 injuries to caregivers, 0 episodes of overuse, and 0 missed opportunities to provide effective care. This brings us to the patient safety movement. This is a movement that focuses on systems and processes that may contribute to patient safety events. So here you see this person having a timeout. And this is a very important patient safety yeah, patient safety intervention that has actually been designed to help with operations and same site, wrong site surgeries. So it's very simple, but it's something that we all recognize that in the past 10 years, we've developed a culture to know that this is something we need to do. We need to have the right person and the right procedure. We need to have a timeout before we start anything invasive. So it is important to acknowledge that humans make errors and to create systems to prevent or catch the inevitable human errors before they result in patient harm. So we're going to share a few stories with you on adverse events, things that actually didn't go very well in patient care. First, a patient's journey, and second, the physician's role in that journey.
I was going in for right ankle replacement. It would be my 20th surgery. I was found 500 club feet. We decided on up-tilt fossa block, which would numb from my knee down for the postoperative pain management for the anesthesia.
I do these blocks all the time. This type of procedure, this is probably the right thing for postoperative pain control. And so she agreed to do it, and we do all of our blocks in the preoperative holding area. So we were set up, fully monitored. She was on her stomach. We were watching everything, blood pressure, EKG, pulse ox, and all that.
I was taken into the pre-holding area where they started to do the block. Within a minute of the injection, I had grand mal seizure followed by full cardiac arrest.
Let's try that one again. So the next one is for the physician's role. That's not the right video. It's part 2, and this being, you'll just have to out. I'm going to do it for you for just a quick. And do you just want to watch it again in a better way? And then we can cut that.
Okay. Another day.
That's the wrong video.
It was the second one. This is what I did.
No, that's not it either.
Steps after? Steps after?
How do you communicate? There's some videos open that are not it. So this is the first video. And
I only had 4 open, so I don't know.
I know, but I think some of the wrong videos are open. This what you report is correct.
No, it's the IHI.
Yeah.
Adriana, can you go up to the arrow and click backward?
Maybe it was.
I knew immediately that she had gotten at least a portion of this local anesthetic into her circulation. So I called for help. We flipped her on her back, and there was plenty of help around, and we watched as over the next minute and a half or so, she went into complete cardiac arrest.
They tried everything for 15 minutes, you know, like the advanced life support, the paddles, everything, and I was still flatlined. At that point, they made the decision to take me over to a cardiac suite, and luckily for me, there was a cardiac suite available that had all the people in place.
And within about 30 minutes of this onset of the event, the patient was on the operating table, had her chest open, keeping the lines and was connected to a bypass machine. Over about 90 minutes or so, we were able to successfully restore her own circulation, her own hemodynamics, disconnect her from the bypass machine, close her chest, and take her up to the cardiac intensive care unit, intubated. Yeah, now it's a cardiac patient and not as an orthopedic patient.
See. Okay. Okay. So, what to report? Basically, when you see this story, you see a woman who goes for a pretty routine procedure, and then a huge chain of event happens. This is obviously something that would be reported, but anything leading up to something like this that it seems that it's not as significant is still important. And so incidents are patient safety events that reach the patient whether or not there was harm involved. So this could be that the patient actually received the wrong antibiotic, but nothing bad happened to them. So that is actually unsafe. They didn't have any harm, but it actually reached the patient. Near misses is a patient safety event that did not reach the patient. And those are very important. And there's many of those. And those are ones that do need to be reported as well. And an example could be that there's 2 bottles in the pharmacy that have almost the same markings on them, and it's very easy to grab the wrong one. And then unsafe conditions, those are circumstances that increase the probability of a patient safety event occurring, which can be staffing or equipment or something just in the wrong location and not available when you need it. So we have another video here to share, just some more information about what to report.
There's a number of things to report. Many people just report when a bad thing has happened, an adverse medical event or a harm event. But if you require harm events to be the criteria for reporting, then the question is, well, how much? And sometimes this can be fairly obvious if you make it gap. But then if you say permanent disability, well, what kind of disability? Or how much harm? Then it brings up the bigger question of what about those cases where there hasn't been significant harm or any harm, but these were close calls or what are called near misses. In this case, nothing serious has occurred, and that's either due to a good catch by someone or just due to dumb luck or happenstance. But it still can reveal a hazard that exists, a vulnerability in the system needs to be addressed. So when you look at high reliability organizations, they really rely on the reports of close calls and near misses. And organizations that don't report close calls and near misses really can be considered to be not a safe organization. It certainly is, I would say, one litmus test of a system that really doesn't understand safety overall. And then as far as level of detail, the detail does not have to be overly great in the report, because as long as it's enough for safety organization to prioritize, and they then will have to go out and develop the information, understand what happened, to have the reporter go into excruciating detail about what they saw, only to be re-interviewed later, which will absolutely be necessary. It makes it a waste of time for the reporter, and they wonder why do they go to the trouble of writing all this down to enter into a system when you ask them the questions later. So this is a case where, remember, it's a safety organization that has to do the job. The reporter's job should be as easy as possible, because all the time should be consumed theirs. And it's up to the safety organization to decide, are these important enough to take action on? If you rely on the reporter to decide what's important, they don't have the same perspective that the safety organization would have. And they might not report things that are important, but they might dwell on things that are unimportant. Rather, you'd like them to have a very wide open report whatever they think could possibly be an issue, and it's for the management of the safety system what is all?
So what to do first? When something isn't going the right way, ensure the patient's immediate safety and provide care. Just like what happened in the video for that person who had a very, very significant adverse event to a pretty routine injection. Obviously, the patient's safety is first. But then after that, what do you do?
Various materials to really fully understand what happened with the function, whatever. So we talked a little bit about the patient. The first thing you want to do is look up the back. You want to make sure the patient's in. So if they need additional care and treatment, you want to make sure that the patient is close to the patient. You want to make the environment safe as well. So you want to make sure that if there's a hazard that exists, that it possibly jeopardize safety of staff or patients. But that's not what. But then you want to preserve information. This needs to be as soon as you can in order to really get to the bottom.
I'm gonna hand over the presentation to Garcia, who's gonna go over the data from Valley-wide.
Thank you. I wanted to, the information you're seeing on the screen, this is in regards to Valley-wide and our resident event reporting. As you can see, we've been, began tracking the, what we call Check It and being inputted into the system. We began January of 2019. So as we continue, and the goal again is to increase this reporting by 20% by June of 2021. So we want to continue the upward trend that we are seeing. So the check-in events entered is, as you can see, over to the right here is just the type of events that we are seeing getting inputted into the system with the severity level, and this was with our calendar year of 2020. So as you can see, the gray is a C category with the event reached the patient but did not cause harm. And we look at each report that comes in, and those are reviewed, and then they are shared. The leadership of the department receives information and looks into these. This is the resident event reporting in for St. Joe's, and as you can see, they have also the same data of reporting we received from January 2019 to April. Again, we want to again increase our reporting, and so we can make changes where necessary. And again, their severity levels, they do a 1 through 5. With the same where it reached the patient but did not cause any harm.
Hi everybody, this is Lilia Parra-Roide. So now what I want to talk about is how to submit an event report basically just recall that this is a narrative of a story, so just a brief description of what happened, whether there was harm or not, and if you happen to know at the time what mitigated the harm, you can say it, and any ideas you have on preventing it. There's separate fields for who, where, and when. So none of that goes into the narrative itself and description of the event. And there's other questions. We'll go show you. At Valley-Wise, the event reporting system is on the intranet, and on the left drop-down menu, you can see where that arrow points to the check it event reporting. And so this takes you to a landing page, which then you can fill out the report. At St. Joe's desktops, there's an icon that says event reporting system that looks like this. Anyone with a network ID and password can enter an event report. So you just click on the icon and that takes you to the landing page, which looks like this. And basically you can see the red fields are the ones that are mandatory. So, so you need to know the medical record number and, fill out the event, so the description of the event. And here's separate fields, also where the event was located and where the event report took place. To build a strong team, you have to be able to see everybody else's strength as a complement to your weakness, not a threat at all. And so take this approach, when you're reporting, you're part of the team. It's not, and you're helping build each other out. So you're not shifting blame or pointing fingers. You're simply pointing out a problem in the system. So Dr. James Reason quote here, rather than being the main instigator of an accident, operators tend to be the inheritors of system defects created by poor design. Their part is that of adding the final garnish to a lethal brew that has been long in the cooking. Here are some do's and don'ts for patient event reporting. So do use factual terms. Stick with the facts that are pertinent to the continuity of care. Who, what, where, when. How was discovered and how it may be mitigated. Again, those separate fields of who was involved. And complete as many applicable sections. But remember, it's more important to get that report out. And if you are missing some details, that data can be collected later. The do nots include, not putting in the description field the names and the roles. These are narratives that can be seen widely by people, and so you don't want people's names in that area. Do not use subjective comments or characterizations, accusations, speculations, or conclusions, and inappropriate descriptive adjectives. And also do not reference this patient safety event report in the medical record. This is protected and confidential, and if you use a reference to it in the patient safety record, it can be subpoenaed. So do not print or duplicate any copies of the event report. Whenever possible, it is important to fill the event report as soon as possible after the event occurred, if possible the same shift. So here's some examples. So this is a same event described differently. And actually this actually happened. These were two different reporters. So 3 hours ago, post-op surgeon A contacted via answering services due to sustained hypotension, 70 to 30 tachycardia. There was no response post 3 events. Also left a message on surgeon A's personal cell. Patient continued to decline. Charge nurse was notified. Surgeon B was contacted. The patient was taken emergently to the OR for a next lap by surgeon B. There was a large hematoma. Patient was transfused, stabilized, and returned to the PACU. Recommendation: establish reliable process to reach providers. Take this example in contrast to this one, which is like Dr. Doe never answers the phone. His answering service is rude. He yells at nurses. This leads to delays. we need a number. Dr. John Doe will actually answer. This is an ongoing problem and management is not addressing his continued poor behavior. This patient almost died. And here's another example. We'll start with the bad one this time. So Nurse Brown was too busy to help this RN transport Jane Doe to the restroom. She slipped on water, which the cleaning staff had not cleaned. Jane Doe's elbow was injured. Recommendation, Nurse Brown should do their jobs and help. Here's a good description. So the unit was very busy and staff were unavailable when patient needed assistance to ambulate to the restroom. This RN assisted alone and the patient slipped on water in the restroom. The patient was assisted to the ground. Patient sustained contusion to elbow. Physician ordered x-ray and there was no fracture. Revisit staff scheduling to address understaffing. All spills and hazards need to be promptly reported. So you can see how there's a lot more detail of what happened without assigning exact blame because we don't even know who left the water in the restroom. So after an event report is submitted, the event is automatically routed to leadership of the involved department and risk services for action. If they have any questions on a specific event, they investigate. But for people that are reporting events, if you want to know what happened, you can actually go to the involved unit leadership and talk to them and be part of the solution. The local team is the one that evaluates and addresses unless it's a very systemic issue that goes across departments. If it's a high harms event, the event will be reviewed by risk management, and risk evaluates trends and does a root cause analysis. And then they prepare reports for regulatory agencies. So event report offers a way to capture unintended consequences and the downstream impacts of system changes. It's a vehicle to identify early signs of system issues. It offers an opportunity to gather diverse perspectives for complex system flaws. It's a convenient portal for frontline staff to have a voice for safety concerns, and an opportunity to recognize staff and support staff in medical errors. You don't just have to report events that are bad. You can report things that are good in the event reporting system. It's a space for collaborative problem solving with diverse perspectives. But we have to remember that event reporting alone will not improve safety. These reports may require varying levels of organizational response and types of action. Event reporting in itself is not a valid measure of safety. So the fact that event reporting goes up just means there's more event reporting. It may represent more events that are harmful, but it may mean that we're just reporting more events, and the fact that we don't report them doesn't mean they're not happening. The practice of event reporting is sensitive to local culture, and it is often peer-reviewed, privileged, and protected. The key here is to try to report events, and not just those that result in harm or that reach the patient. You want to also report events that could have resulted in harm could have reached the patient, especially in those situations that you know this has happened before and you know that it's a problem. Regardless of the path that an event report takes, the overall goal is to learn and make changes to improve systems and prevent future harm. So let's make a difference. Be a part of the solution. So if you're not part of the solution, you're part of the problem. So I just wanted to point out, this is a list of references. So if you want to learn more about the patient safety movement, these are links to the Institute of Health Improvement, which is also known as the IHI. This is a great video to watch regarding Chasing Zero. These are some references that we use for our talk today. For those of you seeking further knowledge, and not only does the IHI have resources, but also Johns Hopkins